Looking at liver function tests, we can see that there are three kind of major tests we'll talk about, ALT, AST, and alkaline phosphatase. But these, although they're known as liver function tests, they're really not measures of liver function. Rather, liver synthetic function would really be measured best by total protein, serum albumin, total bilirubin, prothrombin time, and INR. These would be true tests of liver function itself. But looking at these liver function enzymes or LFTs, we can start with AST, which catalyzes the transfer of the amino group from L-glutamate to oxaloacetate, which forms L-aspartate. The highest concentration of this is actually found in the heart, but then followed by the liver, and it's found in multiple different organs. It's used primarily then to diagnose a heart attack and liver disease, but it's not liver specific, which is important to note. When the source is from the liver, we'll see higher levels with hepatocellular damage versus obstruction. Normal values are here. They are gender assigned at birth specific, with adult males and adult females, females having a slightly higher concentration. And some interfering factors could be hemolysis, which can increase levels. A false decrease could be seen in diabetes, like diabetic ketoacidosis or severe liver disease. Pregnancy could also falsely decrease, and then obesity and medications could potentially vary those values as well. AST increased levels, we can see them from inflammatory conditions like hepatitis, where an increase can be 10 to 100 times normal. Heart attack, pancreatitis, infectious causes like infectious mono, other inflammatory things like dermatomyositis and polymyositis, trauma or disease to the skeletal system, hemolytic anemia, and even fatty liver disease or liver tumors. A decreased level, B6 deficiency, uremia, again, diabetic ketoacidosis or pregnancy, and severe end-stage liver disease could all cause a decrease. Now compare that to ALT. ALT catalyzes the transfer of the amino group from L-glutamate to pyruvate, forming L-alanine. And this is also utilizes B6 as a cofactor. The highest levels are in the liver, so it is a better evaluator of liver disease like hepatitis or acute liver damage, but it also comes from other organs. When the source is higher, there we see higher levels, or when the source is the liver, we see higher levels seen with hepatocellular damage than with liver obstruction. Normal findings also include values that are associated with gender assigned at birth. Interfering factors involve also kind of similar hemolysis, obesity, and drugs or certain medications. If there's a very high increase, we are looking at hepatitis or hepatic necrosis and ischemia. A moderate increase could be skeletal muscle trauma or disease, pancreatitis, severe burns, or end-stage liver disease. Could even be low or decreased. And a mild increase, we look at pancreatitis, heart attack, monomyositis, alcoholic cirrhosis, a liver tumor, or even obstructive jaundice. So if you see a really, really high ALT, that's leaning into hepatitis really, or potentially a hepatic necrosis or ischemia. Now, the ratio between AST and ALT is typically 1. If there is a ratio that is greater than 2 to 3, when AST is really greater than ALT, that suggests alcoholic hepatitis. If it's less than 1, that suggests a chronic hepatitis, either a viral or an autoimmune, or an acute hepatitis. Most liver diseases will see ALT elevations much greater than AST elevations. The two exceptions are cirrhosis or alcohol abuse. AST becomes higher. So that's going to be your kicker is AST is associated really with alcohol, which can lead to cirrhosis over time. Now, another liver biomarker kind of is alkaline phosphatase. This is a group of isoenzymes that are produced in a variety of tissues, including the liver, but also the biliary tract. And the test measures all of the isozyme fractions. So if elevated, you then would need to determine which fraction is increased, or you could look at GGT, which we'll look at next. It's used to detect and monitor liver and bone disorders, and ALP1 is from the liver, ALP2 is from the bone. So some normal values here are listed. There are values that differ based off of if you're in the 1 to 12 range as an AFAB individual versus greater than 15. This is kind of biomarking menstruation. Our AMAB individuals, again, biomarking adolescence and kind of puberty hitting. and then adult male adolescents, kind of in this range. So therefore, these physiologic increases can happen due to bone growth and development, as well as due to puberty and growth spurts occurring. Also, certain medications can change and affect alkaline phosphatase. So if we see an elevation in ALP, we would look at, is it the liver or is it the bone? Because remember, ALP is a measurement of all of those isoenzymes. So in liver disease, we'd be looking for things like an obstructive jaundice, a biliary cirrhosis, a cholestasis, because obstructive and cholestatic processes give a more significant increase than just hepatocellular damage. Hepatitis or other inflammatory conditions like that are infectious, like EBV, Epstein-Barr, or cytomegalovirus, CMV. Cirrhosis or metastatic liver cancer also could lead to an increase in ALP. Bone diseases can vary. Paget's, healing fractures, osteogenic sarcoma or osteomalacia, rickets, osteoblastic metastases that occur to the bone, hyperparathyroidism, and even rheumatoid arthritis. Now, we can see elevations from other sources, which are listed here, some kind of potential confounding factors. If we have a decreased level, we are worried about potentially hypophosphatasia, which is a congenital deficiency of bone ALP, malnutrition or scurvy, magnesium deficiencies, milk alkali syndrome, or even pernicious anemia. Now, I mentioned GGT. GGT is gamma glutamyl transpeptidase, and this helps transfer amino acids and peptides across a cell membrane. We see the highest concentrations in liver and biliary tract and less in other organs, and it's reportedly the most sensitive liver enzyme to detect biliary obstruction, cholangitis, and cholecystitis. So it's really helpful in determining our source of increased ALP. Also, in alcohol consumption, GGT increases in 75% of patients who chronically use alcohol. Some useful information. AMAB individuals have higher concentrations than females due to contribution from the prostate gland. So if prostate is present, there can be an increased level. A normal GGT with an elevated ALP implies a bone disease. An elevated GGT plus ALP implies a hepatobiliary disease. Here are the normal values based off of gender assigned at birth. It can decrease in late pregnancy. It can increase from alcohol and other components or other substances, and certain drugs can also decrease it. Increased levels from a pathologic sense, we think about liver or biliary tract disease, cholestasis, heart attacks or alcohol ingestion, pancreatic disease, infection with Epstein-Barr, and prostate cancer. So then looking across these tests at some patterns, if we're looking at a hepatocellular pattern of the liver, we could look at our markers of AST and ALT and some of the likely etiologies. If we're looking at a gallbladder pattern, a cholestatic pattern, we're looking at ALK Phos, GGT, and bilirubin, and some potential patterns or causes. And liver failure pattern, we're looking at albumin or INR, and that would indicate severe liver disease. Is one flowchart of many. American Family Physician has a really great article on the mildly abnormal LFTs or liver function enzymes or tests. And so what do you do with a mild abnormality in an LFT? So there are a lot of great flowcharts out there. This is just an example of one. Our last test, I'm going to keep it on here just because, well, actually, last test, I'll do a new video. So we'll look at uric acid on its own.